بسم الله الرحمن الرحيم. دكتور أحمد طاهر محمود، مدرس طب الحالات الحرجة، كلية الطب قصر العيني. محاضرة النهاردة عن CPR of COVID-19 patients. طيب، ليه بنتكلم تحديدا عن CPR of COVID-19 patient دون عن بقية الأمراض؟ لمجموعة من الأسباب، أو تحديدا سببين مهمين. السبب الأولاني إن risk of transmission viral transmission during CPR is high. ليه؟ لأن في multiple aerosol generating procedures are involved in this in the CPR. procedure زي tracheal intubation لوحدها carries أو increase the risk of viral transmission by 6 folds. حاجة زي manipulation of oxygen mask increase 4.6 folds, non-invasive ventilation 3 folds on 3 folds, chest compression لوحدها 3 folds. so collectively كل الحاجات دي بتتعمل during CPR، وبالتالي risk of viral transmission during CPR increase ب10 إلى 15 fold أكتر من الطبيعي. مش بس risk of viral transmission، the fact that during CPR multiple CPR providers operate or work in close proximity ده في حد ذاته بيزود risk of cross infection. وآخر حاجة بسبب ال stressful nature of the CPR scenario، الريسك إن الناس ما تلتزمش قوي بال infection control prevention measures and precautions، وإنهم ما يلبسوا personal protective equipment بتزيد، وده في حد ذاته بيزود risk of transmission. so كل الأسباب دي على بعضها بتخلي ال CPR إن ال risk of viral transmission ال CPR of COVID-19 patient is very high. من ناحية تانية إن ال outcome of CPR in those patients للأسف is very poor. الداتا من عندنا من مستشفيات العزل كل العيانين تقريبا حالتهم تدهورت لدرجة إنهم محتاجوا CPR. ال outcome بتاعهم سيء جدا، و specifically ال situation دوت كان addressed في paper published من حوالي أسبوعين من الصين. examined 136 عيان had in hospital cardiac arrest. للأسف only من 136 عيان 18 patients بنسبة 13.2% just had return of spontaneous circulation, and of them only 4 patients بنسبة 2.9% survived till 30 days. صحيح majority of the patients who survived had VT or VF to be considered، لكن still the overall outcome is very poor. بسبب المشاكل ديت we need to balance two things. The CPR in COVID-19 patient has to take into consideration two factors. واحد, we need to deliver effective CPR what the patient needs, بس في المقابل لازم ensure safety of healthcare workers to minimize the risk of viral transmission. Two guidelines were published in the past 1 month addressing this exact issue اللي هو ال CPR of COVID-19 patients. الاتنين متشابهين في حاجات كتيرة جدا. الأمريكان كانت comprehensive أكتر. We will discuss the principle and exact steps in the following slides. الاتنين بيتفقوا في مجموعة من ال principles ديت هدفها حاجتين. واحد, تقلل ال risk of viral transmission. اتنين, to consider أو take into consideration ال outcome. risk of viral transmission واخدينه عن طريق considerations related to reducing the provider exposure to COVID-19 patient and allowing to give oxygenation and ventilation with the least possible risk of aerosolization. And those considerations should be taken in context of considering the appropriateness of starting and continuing resuscitation. إذا كان العيان حالته متدهورة لدرجة إنه ممكن ما يستفيدش من CPR، إذا كان في الأماكن اللي فيها DNR advanced directives، أو على الأقل عندنا هنا إن أنت ممكن considering the patient condition to decide how long do you need to continue your CPR. طيب ال general recommendation ديت ايه هي؟ ال recommendation under the title of reducing provider exposure to COVID-19 includes واحد, طبعا you should don appropriate PPE personal protective equipment for aerosol generating procedure. لأن CPR is considered an aerosol generating procedure, you should be properly protected to perform it. ايه هي؟ عندنا هنا على الأقل requirement من وزارة الصحة ان انت تكون لابس القناع التنفسي على الكفاية ال high efficiency respirator اللي هو ال N95 أو FFP3 equivalent mask، مع جاون impermeable gowns أو water resistant وفوقها ماكنتوش لو هي مهياش water resistant اللي هي الماريال البلاستيك، مع الجلافز، مع الجوجلز أو الفيس شيلد، ويضاف عليهم في situations معينة الأوفرهيد والأوفرشوز. طيب wearing these personal protective equipment properly بالذات لو انت هتلبس ال N95 بالفيت تيست اللي المفروض يتعمل له will take time. Are you going to waste time doing it? Yes, it's not wasting time, it's protecting yourself. Resuscitation Council UK clearly addressed this exact point in its guidelines. It is acknowledged that this may cause a brief delay to starting chest compressions, but the safety of staff is paramount. لازم to spend time wearing all your protective equipments, protect yourself and protect your team. Never start CPR without being fully protected. طيب, along this theme, you should limit the number of CPR provider, ideally 3, maximum 4, and maybe in patient in poor position you need to turn him back, in which case you may need up to 5 operators to do that. But the main theme is to limit the number of CPR provider. طيب, نعمل ايه تاني عشان reduce provider exposure؟ نستخدم chest compression devices لو موجودة. ايه هي ال chest compression devices؟ حاجة زي اللوكاس او الاوتو pulse بتallow delivering chest compression without needing to be very close to the patient to do so, وبالتالي هتقلل risk of viral transmission to the CPR provider. طيب, دي في line of prevention أو reducing exposure of the provider. Along the line of giving oxygenation and ventilation with low aerosolization risk, recommendations إن احنا نستخدم الهيبا filters اللي هي ال HME with bacterial viral filters and connected لل ventilation device sign can bag mask أو endotracheal tube، أو لو هنستخدم laryngeal mask superior airway should be connected to it as well. طيب, لو هنركب أو هنحتاج ventilation، ال guidelines بتrecommend inserting an endotracheal tube over using a bag mask device. ليه؟ لأن risk of aerosolization هيبقى أقل وانت بتركب أنبوبة في عيان cardiac arrest من ان انت تستخدم باج ماسك ديفايس. ولو هنركب الانتراكيال تيوب المفروض سينيور اوبريتور هو اللي يركبها the first chance او highest chance of first pass success. وان احنا during الintubation as you can see in this simulation مفيش chest compression, we should pause chest compressions. Okay, as you can see مفيش حد بيعمل chest compression while the operator is inserting the balloon. طيب, لو في video laryngoscope and we are trained to use it, we should use it. It allows intubating the patient without looking directly in the mouth of the patient to minimize aerosolization. عندنا generally two types of video laryngoscope, one with a screen mounted على الهاندل والتاني with a screen connected to the laryngoscope via a cable. This format allows even the operator to stay away from the mouth of the patient as you can see in this example. طيب, لو هنحتاج pre-oxygenation, and we always need pre-oxygenation, it's better to deliver that by non-rebreathing face mask over bag mask ventilation, again to reduce the risk of aerosolization. And for any reason, if there is a delay in intubation, we should use tight sealed, and again we should stress this word, tight sealed bag mask ventilation or supraglottic airway. اذا كنا كده لازم هنستخدم باج ماسك فنتريشن فلازم يتم استخدامه بريكوشن. يوجوالي هنحتاج ان هو يبقى تايت سيلد، وعلشان يبقى تايت سيلد في الغالب هتحتاج 2 operators. One operator will tightly seal the mask over the patient face using the VE technique, in which the thumb and the theory eminence is above the mask, the index is at the chin, below the chin, and using both hands to seal the mask. You should never use the CE technique, single operator technique, to tighten the bag mask ventilation to the patient. And even if you use the CE with both hands, it's not as effective as the VE technique for maintaining the seal of the face mask. Finally, once the endotracheal tube in place, we should minimize disconnection, and to do so, if we have a closed suction unit, you should use it to minimize circuit disconnection. طيب, تاني, كل recommendations في under the category of reducing the provider exposure or giving ventilation with the least aerosolization risk should be taken into consideration within the context of considering the appropriate of starting and continuing resuscitation of the patient. طيب, how do we put these in exact algorithm? This is what we're going to discuss دلوقتي. On suspecting cardiac arrest situation, a recommendation في guidelines ان انت to avoid local listening and feel. You just check for responsiveness, pulse, and observe for respiratory movement. Avoid bringing yourself close to the patient to check for breathing. في اليوروبيان أو في البريتش guidelines بيدرس ال CPR in 3 phases. أول phase if you suspect cardiac arrest، أول question هو إذا كان عيان في DNR situation إذا كان في directives for do not attempt resuscitation or do not attempt cardiopulmonary resuscitation. Of course if there is you won't continue, but if there isn't we will move on to the next phase. next phase في ال British recommendation بتفترض ان انت جنب العيان مش لابس ال full personal protective equipment for aerosol generating procedure، لكن لابس ال equipment for level 2 اللي هي عندنا في مصر السيرجيكال ماسك بس، مش ال N95 مع الجاون والجلوفز والفيس ماسك او الجوجلز. لو انت مش fully protected بس لابس السيرجيكال ماسك وواقف جنب العيان وحصل فيه سيرجيكال ايرست، ال Resuscitation Council UK gives you the chance ان انت if the patient needs cardioversion you can attach the pads and cardiovert him if he has a shockable rhythm. Okay, this is the only thing that you can do without wearing a full personal protective equipment for aerosol generating procedure. Although this is still not very recommended because there is a risk of aerosolization with cardiac compression, although low, لكن with defibrillation although low, لكن this is something you can keep in mind if you want. Now once personnel with proper PPEs are available ماشي then we move to phase 3. American Heart Association addressed this phase liberally أكتر فهنتكلم فيها. ال BLS كلها وال ACLS بدايتها بتفترض ان كل personnel involved are wearing a proper personal protective equipment, okay, with the least number of personnel needed for the CPR. You will check pulse and respiration. If the patient has pulse but no respiration, then we will give bag mask ventilation taking the precautions we discussed before. Connected to HEPA filters and using two operator, one of them to ensure tight seal on the face of the patient. Once properly placed a bag mask device, we will deliver breaths 5 to 6 every 5 to 6 seconds with a rate of 10 to 12 breath per minute, and we will check pulse every 2 minutes to check for any signs of deterioration of the patient. Now if there is no pulse and there is no breathing, then we will start cardiac compression provided that we are wearing the proper protective equipment for aerosol generating procedure. Now cardiac compression in this case should be according to the standard. We'll discuss them in a minute. And in this situation we can deliver oxygenation with a non-breathing face mask and not necessarily using bag mask ventilation. The guidelines gives you the option to use either of them, but again the guideline itself acknowledges that the risk of aerosolization with continuous compression with passive oxygenation with face mask is lower than that with using bag mask devices. So once we deliver compression, we should make sure that the compressions are hard, 5 centimeters, fast, 100 to 120 pushes per minute, allow chest recoil and minimize interruption, avoid excessive ventilation, and if you decide to use bag mask ventilation, maintain a ratio of 30 to 2. It's essential if possible to monitor the adequacy of chest compressions either endotracheal by Untitled CO2 aiming for values above 10 millimeter mercury, or by invasive arterial pressure monitoring aiming for a relaxation phase pressure above 20 millimeter mercury. Okay, so after that we will check for shocks for shockable rhythm. If the patient has shockable rhythm we will shock him, and if not we will continue compression, and this is where advanced airway come in place. In this step you should move on to insert an endotracheal tube with the precautions mentioned before. That is senior operator, highest chance of first pass success using videolaryngoscopy with the tube connected to HEPA filters, and once the tube in place connect close suction if available to minimize circuit disconnection. And should confirm the position of the tube with Untitled CO2 capnography, and once in place you deliver 10 breaths per minute irrespective of compression, and continue compressions uninterruptedly. Then we move on to CPR for 2 minutes and check the rhythm again. If the patient is still in non-shockable rhythm, whether PA or asystole, we would give adrenaline and continue CPR for 2 minutes and continue giving adrenaline every 3 to 5 minutes. And this is the place where, if we have cardiac compression devices, can install it and use it. If the patient has a shockable rhythm, after 2 minutes we will shock him and give adrenaline and continue giving adrenaline every 3 to 5 minutes. And also, if we have a mechanical compression device, then we would use this, and after the third shock we should start amiodarone or lidocaine as needed. So في two special situations are addressed in this guidelines. السيتويشن الأولاني هو لو حصل cardiac arrest في patient already intubated وعلى mechanical ventilation. The recommendation is to keep him on the mechanical ventilation and not disconnect him, provided that محطوط على أو إن في HEPA filters are in place and the tubes are in place. إن الأرست ما حصلش بسبب tube dislodgement أو tube removal. Once the patient is in ventilator, once the patient arrests while in ventilator, there are few changes that need to be done to the ventilator to ensure safe delivery of breaths. واحد هنعلي بالFI2 لماكسيموم 100%, and we will adjust the beep to balance venous return and lung volumes. Of course, intrathoracic pressure will reduce venous return and consequently the chance of return of spontaneous circulation, but on the other hand it will also reduce lung ventilation and recruitment, so you need to balance that against each other. The next change is to change the ventilation mode to pressure controlled ventilation and adjust the pressure to deliver tidal volume of 6 milliliter per kg ideal body weight. Adjust the rate to 10 breaths per minute, and very importantly, turn off trigger to avoid auto-triggering and barotrauma, and of course keep monitoring the tube to avoid dislodgement or disconnections. The second situation, special situation, is cardiac arrest in prone patients. More and more proning is used in COVID patients, سواء الأويك proning أو proning in ventilated patients. Of course, after ensuring proper use of personal protective equipment for surgical procedure, further steps بتعتمد whether in this patient has an advanced airway ولا لا، يعني معمول له awake proning ولا لا. If cardiac arrest happened in patient without advanced airway, the main theme is that you need to return the patient to supine position to be able to continue resuscitation. However, turning the patient to supine position will take time and will take more personnel, so you need to call for help. And while help arrives, you will do the following. First, place an under-breathing face mask to deliver effective oxygenation. 2, start cardiac compression in prone position, and where to place your hand is on the back of the patient opposite the thoracic 7th to 10th vertebrae, which is opposite to lower 1/3 of the sternum in supine position. How do you know this place? Is palpate for the tip of the scapula, interscapulary, put your hands between the two scapula. This is opposite the thoracic 7 to 10, and start compression following the same precaution of pushing hard, pushing fast, allow complete recoil and minimize interruption. And to check for a rhythm, there is a recommendation to connect defibrillation patches to the patient in prone position. And where to connect them? The best position for pads is the anterior posterior pad position. ليه؟ لأن دوت encompass the largest part of the myocardium in the vector of shock. Okay. However, placing the anterior pad will require rolling the patient to one side to be able to place it, which might not be always possible during CPR. An alternative to this, less effective, little bit less effective, but alternative is the apical posterior position, in which you place the anterior chest pads in the mid-axillary line, slightly anterior, and the posterior patch in standard position. Okay. There is a third location, which is bi-axillary, in which one pad is the right and the other in the left mid-axillary line. There are reports of it being successful. However, it has the least chance of success because it encompasses large parts of the lungs in the vector of shock, allowing delivery of small amount of energy to the heart. Okay, so you can attach the pad, check for shock algorithm, and shock the patient if needs. Then after the shock, you consider returning the patient from prone to supine position, and this needs to be coordinated to be done quickly with very minimal interruption of chest compressions. And in this video I will show you a simulation to how to do this. Observe that you need many personnels in the room to do that. Okay, chest compression started, the patches are being connected, and in this simulation they are connected in the bi-axillary position. And once the patches are connected, you will check for the rhythm. And in this simulation the patient does not have shockable rhythm. You will only interrupt compression just before checking the rhythm. Once the decision is made, compressions should be resumed, and now all other personnel will coordinate to turn the patient to supine position. A bed sheet is placed over the patient and rolled with the sheet under the patient on this side, as you can see here. And once this side is complete, the provider will swap to continue compression, and the other provider here will roll the bed sheets on that side. And only when both sides are ready, then compressions are stopped, coordinated to be pulled to one side, turned over to his side, to the patient's side, changing hands, and then continue the turn to supine position and resume cardiac compressions. Took only like 20 seconds to do that, and then continue CPR as previously described. So the other scenario is that if a patient rests in prone position while connected to mechanical ventilation, again the same precautions for personal protective equipment apply, and in this scenario we will keep the patient connected to the ventilator and adjust as advised, and deliver the whole CPR in prone position. We will start compressions in prone position opposite T710 as described before, and we will attach defibrillation pads in the same position as also described before, and continue the whole CPR in prone position. So our take-home message is that of course we need to balance what the patient needs and the safety of healthcare worker, and we should take all these consideration about the effectiveness of CPR and the reduction of risk of viral transmission. But we should always keep in mind that team safety is our maximum priority. Thank you very much.